mentales. Ahora daremos paso a una conferencia de la doctora Juliana Lynn Restivo, quien nos hablará desde su experiencia en el Global Mental Health de Harvard Institute. Déjenme comentarles que la doctora Juliana Lynn es coordinadora del programa global del Mental Health Department of Global Health y Social Medicine de Harvard Medicine School. Ella nos va a hablar en inglés, va a haber una traducción simultánea de su participación. Por favor, aquellos personas que requieran la traducción pueden ir al botón que está abajo del Zoom que dice que tiene un mundito, escojan el idioma de su elección. También déjenme comentarles que la doctora Juliana tiene una licenciatura en Biología y Psicología por la Universidad de Loyola en Maryland, Estados Unidos, una maestría en Salud Pública en la Universidad de Boston. Es coordinador de la iniciativa Global Mental Health de Harvard y asistente del profesor Vikram Patel, asistente ejecutiva de la presidencia del Departamento de Salud Global. Demos la bienvenida entonces a la doctora Lynn, por favor, y yo voy a ir identificando sus preguntas para podérselas proporcionar al final de su intervención. Adelante, doctora Lynn.
Hi, everyone. Thank you so much for having me at this conference. I'm excited to share our work that is at Global Mental Health at Harvard, and I hope that you can see my screen and hear me well. Thank you for translating as well. So I will be talking about our efforts to scale up mental health care globally through evidence-based psychological treatments. And as said in the introduction, I'm the program coordinator for Vikram Patel's Mental Health for All Lab, as well as his Global Mental Health at Harvard initiative, which is where most of this work is based out of. So as many of you know, mental health is a global crisis, accounting for greater than 14% of years lived with disability, much greater than cardiovascular disease, cancers, and diabetes combined. 2/3 of that global burden of mental disorders are focused on mood, anxiety, alcohol use, and trauma-related problems, which many of us call common mental health disorders, which is most of what I will be speaking about today. And low-income countries devote less than 1% of their national health budget to mental health. But as I will share, this is not much less than what higher income countries do as well. 80% of persons who need mental health services globally lack access to quality care and sustainable care. And healthcare costs rise by 50% when mental illness co-occurs with other problems. And it is projected to reach $6 trillion by 2030 in global costs if we do not address these mental health disorder problems. So for global health research and individuals working in global health, why does mental health matter? I'm sure many of you can consider why, but here are a few reasons that we always highlight. Mental health must be integrated into primary healthcare settings. These primary healthcare settings are already dealing with mental health care, and they're already dealing with mental health problems, and yet many don't feel, of the health workers don't feel that they're sufficiently trained to handle these common mood and anxiety disorders. Like I said earlier, in the context of mental health, many higher income countries are also still developing when it comes to their mental health care system. There's gaps for common conditions often exceed over 50%, and in classified low-income countries, this gap exceeds over 90%. And this contributes to other diseases as well. It exacerbates and worsens outcomes of other illnesses, as well as increases the poor mental health for those people who do have those. And community health workers and other frontline workers represent an essential workforce that we need to work with in order to address this gap. So a few key barriers to improving this access: content, supply, quality, demand, and the narrow approach that is still taken. I'll start with the narrow approach. In many parts of the world, there is still a biomedical focus on mental health and focusing on diagnosis of mental disorders, which doesn't capture the varying degrees of severity. And we've especially seen this varying degree of severity during COVID. When we talk about burnout, when we talk about anxiety, uncertainty, these may not be severe mental illnesses, but they still fall on this spectrum. So a narrow approach of only biomedical approach to mental health care needs to be expanded. There's also a stigma, and I was listening to the talk earlier, and I know there was some mention of stigma in general, and there's a stigma of being diagnosed. So if we only focus on this narrow approach, it limits people from seeking care from professionals. And we also have to remove the stigma for those who do need serious mental illness, do need help for serious mental illness as well. It is extremely expensive and difficult to scale up treatment and scale up the quality of that treatment. We talk a lot about training community health workers, but what does it mean after they're trained? We need to implement supervision measures. We need to implement quality measures to make sure they feel like they are getting the support that they need. And this is expensive and difficult to scale up, so that I'm going to talk about some programs where we're working on that as well. There's also a massive shortage of skilled providers, especially in low resource countries. But when we talk about skilled providers, sometimes the only thought goes to psychiatrists and psychologists. But when you think about social workers, when you think about therapists and trained community health workers who aren't trained, we call them non-specialist workers, not trained in mental health care, there's a massive shortage in this people who are trained. And content. The content for psychological disorders needs to be tailored for need to be tailored for culture, for context, taking into language account, gender. The same people may not translate depression and anxiety and stress the same way. Maybe a direct translation may be worry, maybe scared. Those things need to be taken into account to really meet the needs of people who are feeling this way. So access to evidence-based mental health care is limited, as I said. Psychological treatments are effective interventions, and despite this evidence and the preference by many patients that we've seen in the research, most populations do not have access to trained individuals. So this failure to deliver brief, low-intensity treatments is really the biggest challenge in addressing mental health programs globally right now. So how can we meet this need? And one thing is focusing on redesigning the workforce, as has been done in many different sectors of health. And when we focus on community health workers, when we focus on peer support specialists, which are very important for mental health, because to see someone as a peer who has gone through what you've gone, how we can move forward to addressing these barriers by redesigning the workforce. And by doing so with that, we want to focus on the community health workers. And I believe right before I cut off, I was talking about peer support specialists and how these peer support specialists, particularly for mental health, are very important because they have gone through lived experience, and they can share this experience while being trained to also assist individuals in need. And this really greatly enhances our capacity to address mental health and addiction in communities and decrease the demand on that very limited supply side of skilled therapists and psychiatrists and psychologists. So when we're looking at this model, really focusing on prevention, awareness, and early detection for referral of those severe cases. This is not to say that individuals, do not need more severe care, but early detection is really important. So when we redefine what does it look like, what mental health interventions look like, these are some community components of mental health programs that the colleagues at George Washington University have highlighted as very important to focus on. So we look at the what, the where, who, and the how. And what is really focusing on anti-stigma, psychosocial education, skills training, and psychological treatments. The where is in places in communities where people feel welcome, they feel comfortable, and it doesn't feel like a medical diagnosis, looking at homes, schools, religion centers, and community centers. For the who, this is also really important to make sure that we're reaching people and we're training individuals who community members and patients feel comfortable with. And this isn't to replace the mental health workforce, but it's really to expand on that first line of contact. And how, looking at community-based findings, service users, and integrating into service platforms. So a few things that I've mentioned, but solving the content barrier, we want to make sure that psychological therapies are developed with active components that make it less complex for these individuals and for those who are trained as well. So breaking down programs such as problem solving, behavioral activation for depression, exposure, parenting, that's important to really increase the access. Training non-specialist providers effectively to deliver this care really addresses the supply barrier. And there's a number of research studies, over 100 randomized control trials over the past decade that have looked at the ability for non-specialist providers to effectively deliver this care. And a lot of the work that we're also doing is looking at digital technologies, which have only expanded. Digital literacy has only expanded during the COVID-19 pandemic for many, while this received a lot of pushback and still does in areas where we're still trying to reach places with limited Wi-Fi or lack of digital literacy. Being able to train providers at this level is also a very important tool. So I'm going to talk about one of our studies called Essence, and this is a trial that recently concluded, and we were comparing the training of ASHA workers in India, who are community health workers, to deliver a brief psychological treatment for depression, which is called the Healthy Activity Program. So like I mentioned, our Essence project is based in India, and it is one of the National Institute of Mental Health's scale-up hubs, which is research partnerships for scaling up mental health interventions. And I'd be happy to provide more information about these other research studies, which are doing phenomenal work. And I know many of them are wrapping up as well soon, so we'll see results from them too. So our study takes place in Bhopal, in Madhya Pradesh, a state in India. And this is based out of our implementing partners at Sangath, which has reached 25 years of action this year. So our accredited social health activists are community health workers instituted by India's government. And they feel like that they are already doing counseling in their communities, and they just don't know how to recognize a need for this change and a need for referral systems. So they see this as a high demand for training. So we had engaged with them in developing the digital training. And many of them wanted this digital training because they feel like it's less of a burden on them to travel for face-to-face training. They can learn wherever. It's better for them with their families. And they also feel like they can continue working because they get paid. If they leave for 4 to 5 days, they won't be paid for that. So we have to make sure, as we're scaling up our trainings and as we're scaling up programs for community health workers, that they that they're also being paid and compensated well. So this was a big barrier that they highlighted for us that was important for them. So some key insights from them also was that there was the importance of depression training. They were happy to learn more about digital technology, and that increased their digital literacy. And they also had high engagement with the digital training. So as I mentioned, the Healthy Activity Program is what we converted into a digital program. And this was based on the premium trial, which showed the effectiveness of the Healthy Activity Program. And the systematic process for digitizing this training from the blueprint of the manual to the digital format was followed here: blueprint structuring, draft review and finalizing English, then translating and filming and editing and adding the content to the digital platform. So this was a whole process before we even had the ASHAs trained. And then the course orientation, because there was also involvement in making sure that this digital literacy was met as well. So next steps, moving from that randomized control trial, we have this initiative called Empower, which is building the mental health workforce. And this is based on the need, from what I was saying, the opportunity to take advantage of the science that's been in the literature for a number of years, and to expand on that. And through these methods, this is what we know now, that non-specialist providers can deliver care. Peer-to-peer models are effective for also supervision of care, to make sure that quality supervision is given, and that digital training, delivery, and supervision is effective. And this has even expanded during COVID. So very briefly, the Global Mental Health at Harvard initiative was started in April 2018, and really, builds off of the contributions that many in the Harvard community, including Professor Vikram Patel, Professor Arthur Kleiman, Professor Shekhar Saxena, and many others have contributed to through these writings. And we have 5 structural barriers that our priority work streams are hoping to address. And for 3 of them, I've mentioned one so far, the Empower Project, but for the other 2, we have the Engage, which is making sure to engage and empower persons with lived experience. We have a book that recently was published in September of 2021, Mental Health, Legal Capacity, and Human Rights. And this book brings together legal experts, mental health professionals, self-advocates to discuss the research agenda and practical considerations of the Convention for the Rights of Persons with Disabilities, to really prohibit, to advise and prohibit countries and regions from involuntary treatment of persons with mental disorders. It's a really fantastic book with writings from all over the world. So I would highly recommend, if you're interested, to check it out. The Empower Project, like I said, you can find at empower.care. And that is our initiative to work with health systems to train their workers through the digital platform that was developed from the Essence Project, to really build the mental health workforce and to expand the trainings for those in primary healthcare settings. And then Countdown. For Countdown, this is an effort put together by the United for Global Mental Health, Global Mental Health at Harvard, WHO, and many other partners. And this is really looking at the indicators that have not really been considered when it comes to the mental health services in countries. And in saying that, these metrics are going to look at the mental health system, just like the WHO Mental Health Atlas has looked at, but it will also look at social and economic risk factors of poverty, food deserts, and really determine the monitoring and evaluation of these countries. So you'll see, if you are following the mental health work, you will see publications of this from the Lancet over the next few years for the Countdown, Global Mental Health 2030 Countdown. And these are just some events that I hope many of you will join if you're interested. For our Global Mental Health at Harvard, these are webinars, particularly our How Did I Get Here? Career Paths in Mental Health, which range from students or people switching careers So I can provide a link to our newsletter if you are interested in signing up. So key messages for reimagining mental health, just to close, really looking beyond as clinicians, as policy, as researchers, beyond the narrowly defined and diagnosed mental illness, and really focusing on the community, building and leading the redesign, emphasizing social justice and equity to reduce the disparities and eliminate coercion in mental health care, and adapt interventions for the local context with careful consideration of culture, gender, language, and others. And really leveraging technology, not necessarily for telemedicine, though we have seen that expand, but really leveraging it for training and supervision as well for health workers. And opportunities for reciprocal learning from low-income countries to high-income countries, where normally what we see is knowledge coming sometimes from high income, and then instructing the way policies are created in low income. But really, the mental health field, with everyone at an equal playing field, there's a lot to learn from both directions. So thank you very much, and I'm very sorry for the mishap with the Wi-Fi before. I don't know if there's any questions.
No se preocupe, muchísimas gracias, doctora. Sí, doctora Lynn, vamos a ocupar unos momentitos para hacerle unas preguntas que llegaron del público. Le guardamos el resto porque llegaron muchísimas en torno a su presentación. Y básicamente les gustaría al público conocer cuál es su opinión sobre los servicios de salud mental en México en comparación con América Latina o Estados Unidos, si es que usted puede dar una opinión. Y sobre todo, ¿qué podemos aprender? ¿Qué lecciones podemos aprender en relación con los problemas de salud mental? También, si hay algunos trastornos de espectro autista que se estén considerando dentro de sus trabajos y hasta dónde se han llevado, si hay escuelas de educación especial o programas dentro del Harvard Institute que usted pueda platicarlos, ¿no? Por último, preguntan si detecta si hay alguna diferencia significativa entre la herencia étnica en Estados Unidos respecto a los problemas de salud mental, es decir, si las minorías migrantes o de algunos grupos étnicos tienen más dificultades en términos de salud mental que otros grupos poblacionales.
Great, thank you. So let me start with the autism question, because some of the work out of Sangath has been focused on research projects, particularly for parent interventions of early detection for autism. And I think one lesson, even though that work is based in India, one lesson that can be learned from that is, especially in child development and child mental health, it's so important to bring together the whole family. And it's not only the parents, really some of the programs are expanding within the family and making sure that, there's programs and understanding for early detection, but also for treatment in the expanded family. I think, in India, it's very family-based or family-oriented. And from what I know, and in the Mexican and Latina culture, it's very family-oriented as well. So you can't only have interventions that target the parent, it needs to target the whole family. So that is some research that I know is happening at Sangath. And if you're more interested in autism, I definitely would recommend checking their program out online at sangath.in, and you can see some of their autism work. Let me see. So one of the other questions about specifically Mexican and Latina communities, I don't work in our work in that field, but I think lessons that can be learned are similar to the autism, really making sure that everyone is included. And also when you're tailoring different programs, it's for mental health, it's very important to pay attention to regional differences and, dialects, and making sure that is also contributed to these training programs and also contributed, edited when it comes to the delivery of these psychological treatments. Because even in India, I mean, there are so many different languages and differences between the urban areas and the rural areas. And really targeting mental health, we can't use a large one blanket fits all approach. It needs to be tailored. And that may take more time and it may take more work, but that's the only way that we're going to reach those in need is if we really tailor to the specific understanding of these mental health problems, especially for common mood and anxiety disorders. I'm trying to think if there was one more question that I can, from what you had said. Is there another one that I can mention?
Sí, es muy poquito el tiempo que ya nos resta para
Yes.
empezar la otra mesa, pero no, en realidad era sobre cuál era su opinión respecto de las políticas de México y cómo podíamos tomar esas buenas prácticas o aprender de ustedes o de lo que están haciendo en el instituto para reforzarlo aquí en México y en otros países de América Latina que también nos escuchan en este congreso.
Yeah, I think one thing that our work has also focused on is making sure that not only clinicians or community health workers are trained to understand this, but there's a program and on one of my slides that hasn't started yet, but it's called Champions, and it's training leaders in government, in business, in economic positions to understand the resources needed for mental health. So I think moving beyond training community health workers and beyond training clinicians who actually work with patients, that's one solution. But we're coming up, and hopefully down the road will be a certificate for champions of mental health, for people to actually receive a certificate and say, okay, I have the knowledge as a mental health leader to understand the needs of these communities and to implement policies that can support them. So I think that's something at a broader level beyond the community health work and beyond the patient level that we need to pay attention to, and people in leadership roles need to be trained in that as well. So hopefully that you'll be able to see that soon.
Muchas gracias, doctora Lynn, por su participación y le invitamos a mantenerse dentro del evento porque continúa.